Today is our second training. It's our fast and furious and brief training, and we're going to focus today on measurement, okay? Measurement is the word for the day. And but first, we're going to go through each group, and you're going to share your update on the homework that we had, and we're going to use it as an opportunity to help each other and provide feedback on where you're at, and hopefully we all can learn from each other as well as provide feedback to make your project better and strengthen where you're going. We're going to talk about different ways to measure very quickly, and then we're going to talk about measuring our baseline and look at a run chart as an example. Okay, so that's our work for today. Ed, I am going to start with you. And I love how you put the Michigan logo above the Cincinnati one.
Well, it's quality improvement, quality improvement.
Yeah, that's awesome. Okay, so hit it.
Okay.
It's all yours.
All right. So we're the adult care QI team. That's the team that we are. Go ahead.
Yep.
And what I've done is I had this large group of people that was interested. So the first thing I did was I said, let's pare this down. Who here actually is going to be able to help us do this project because they actually have a clinic where they see adults? So there are four respondents to that, which includes my team, the Columbia team led by Dr. Hee-Kyung Kim, and Jason Carmel's been representing them at the meetings, Gary, and then Steve Nichols from Baltimore, Mount Washington, all have a significant amount of adults in their clinic. What I'm going to do next is find out which of these teams are either actively doing CPRN or are very close, like our team is, to getting started, so that we know who actually can be using CPRN to help us with data collection for the project. And we'll see if that keeps us with 4 teams or probably pare us down a bit. We'll see where we go from there. Next slide. So there's a group of consultants, other people that were interested who've been come to the meeting, but don't really have the adults there, which includes the folks you see here. I should also mention includes Paul and Amy in the group. The nice thing about the group is it has clinicians, it has people like Susan Horn that have research expertise, of course it has clinical researchers, and it has a family like Paul, and Duncan Wyeth, of course, is an adult with cerebral palsy. Go ahead. So what are we trying to accomplish? So we wish to improve the care. Hang on one second. Let me just move myself around here. We wish to improve the care for adults with cerebral palsy. In particular, we hope to have the big hairy audacious goal is to improve the care of adults with cerebral palsy. When you get more specific, in particular, we want to have an impact in at least 3 major areas of care. So what we did is I had people fill out a matrix and kind of indicate what they thought were the most important areas of care. And I could share data. Sometimes people are interested. It's not that interesting, but the thing is that pain, functional change, and mental health issues came back as the highest rated ones. Mental health issues was kind of close with cardiometabolic health and bone health. So among those 5 issues, we'll certainly look at pain and functional changes, and then decide on the third issue, kind of depending on the focus of the groups. And then if we're going to have a 4th issue, but that may be too overwhelming. We'll see if we're going to go with 3 or 4. How will you know a change is an improvement? So what we want to, what we've been discussing, what are we going to measure? So I'm discussing the use of standardized measures and adding in PROs as a way of doing this. And that's based on the assumption that if we measure better, we will have better outcomes, which is it's an assumption, but I think it's an assumption that we clinically understand that seems to work that direction. Alternatively, we're talking about measuring whether an intervention took place. So was the patient asked about pain, and did the caregiver respond to it, or just note it in their documentation as being the QI thing that we look at? So the first issue is, was the problem discussed and evaluated? And then, that's the basic thing that we want to look at when we do our retrospective review. And then we want to get an understanding of, do people do standardized measures, and how to respond to these questions. Next slide. Amy, there. And so, we're right at the refining the scope and charter of the project, and we've not gotten yet to document occurring state.
Great, thank you. So how would you, does anybody have any questions for Ed after hearing that? You mentioned going back to look at did people document? Have you looked into how are you thinking you might do that?
I'm thinking we would come up with a protocol for pulling like 20 charts per clinic and taking a look and seeing. And then, we have to think about, do we need to look at different GMFCS levels, different ages, young adult versus older adult versus middle adult? We have to think about those in those lines.
Mm-hmm.
And doing that. So if we were to look at this as different projects in different clinics, so of course we would ask each clinic to focus in on in their retrospective review of looking at that particular problem. Although it would certainly be time efficient to have everybody look at all the problems that we're trying to look at, just to have that data. But I think that's what we would do.
Okay.
It's great to see pain come up, Ed. I think that's so important. It also came up in our survey. The functional changes, if you're thinking about standardized measures, what sort of ideas did you have?
That's a challenge, Darcy. And, I did some work. I published a paper on long-term outcome of rhizotomy, and we didn't really have a good functional change measure. We asked a few questions, documented the amount of care that they need and that they needed over time. I don't have a great answer for that.
Yeah, that one's a tricky one. Okay.
Yeah, but you start with asking people, do you think you've had a functional change?
Yeah.
And how would you describe it? At least you got to ask. And then the question is, what do we do about it? And that's a little tricky too, because you definitely don't have an algorithm that says, patient has functional change, so I'm going to do X. It's patient has functional change, so I need to do a good history and physical. I think that's what it comes down to. And then there's 50 branches off of that.
Yeah, just a quick question. Could you just use a measure of function and then let the measure tell you when change happens? Is that possible?
Yes, Jacob, yes. And there are functional measures. But I mean, that would entail making sure that you, it's a little different question is, do you measure function every clinic?
Mm-hmm.
Which is a great question. It's a good question.
Mm-hmm.
And that would help us with the functional change question.
Good. I like that you're thinking that the first thing is to say, did the care provider ask about pain and document that? Did the care provider ask if they've noticed any functional changes and document about that? I think that's going to be where you're going to start. But your homework is going to be go and look in 12 charts or whatever number you decide and see if you can capture that to see if what you think you're going to measure is measurable. And then the interventions you decide on, like using a PRO or putting something in an epic flow form so that the provider then asks about that and finds out that information. So stick with the beginning part of this, like is the care if I look at 20 charts, how many was it indicated that the care provider asked about pain and document? The only way we know they asked about it is if they documented it. Unfortunately, if they asked and didn't document, it's as if it didn't happen. That's the
right.
rule.
That's correct. And I guess the other point with that is that if I go through and I see in every chart they mention pain, so then we have to ask a different question, right?
We'll see. First, you have to. It depends. We'll get to that. Are you asking, did they measure pain? And then
right.
Yes, your next thing might be, did they do something about it when it was yes?
Yeah,
True.
Or did they measure it correctly? Did they measure it? If we start with did they just ask about it, then I'm not saying you have to ask a different question. You have to move away from pain, but we'll have to go back through and ask a deeper question. So
yeah. So yeah. I think you won't know as you are looking at your baseline and looking back at 12 charts or 20. You're going to refine your measurement and what you're measuring and what your aim's going to be. This is all this all goes, we're always refining this. That's why every time we meet, we're going to do this. You're going to go through a few slides and show me where you're, tell us where you're at. So great.
Yep.
Can we,
Amy,
let's move.
I know you want to move on. I want to ask just one quick question. And the work that's been done with the adult study that has a whole functional section, I mean, many of the prongs of the adult study are standardized measures. I assume that is not that doesn't qualify as a validated measure of functional change. It's kind of ask the patient whether or not when they had their best functional year and have they declined since then. I assume that is not your functional change measure.
It's not they're questions, Paul. They're not validated measure.
Yeah, okay.
Mhm.
Great. That's what I thought. I just wanted to get
Yeah.
educated. Thanks. Go ahead, Amy.
And what you might see when you look through the charts is that not only is there variation on if they asked about it, but how they documented it. Some people might fill out, a Likert scale pain thing. Some people might do something else. So there's going to be a variety of ways. So again, one of your interventions on the right side of this key driver diagram might be standardizing the way caregivers ask about and document pain at these clinics or something.
Right.
Adults. And I also like the idea of looking at, you decide what age or what GMFCS levels, and maybe it makes sense to focus in on a specific group. So that's good. Next, I think I'll just present the hip thing that Wade sent me. This is his hip health team. And this, I think, is sort of the whole team. And then this is the, each team at a center, Nemours, and then nationwide. I don't know who Kevin McCormick is, but he's certified in Six Sigma, which is another improvement methodology. So that's good. They want to improve compliance with the institution's accepted hip surveillance protocol, and they think they're going to measure the percent of patients at GMFCS 4 and 5 that receive hip x-rays, and they'll take this measurement, they'll collect this data monthly in CP Clinic. So does anybody have any suggestions for how to make this more specific? If you're going to improve compliance with the hip surveillance protocol and see who's received hip x-rays, like, I don't know what's in their protocol, but what types of things would you need specific information on in order to collect this data accurately?
It seems that if it's a protocol, it's more than an X-ray, and so it seems like you would need other pieces there. It also needs some kind of a time frame. This is all based on time, and so imagine there are certain actions that are taking it along a certain continuum.
Yeah, and I wondered, so how often do these kids come to clinic, the 4s and 5s, and do you get an x-ray every time they come?
Mm-hmm.
Or
See, you don't, because some come for Botox every 3 or 4 months. Obviously, you don't x-ray them every 3 or 4 months.
Right, so he's going to have to define that in his operational definitions.
But this may be in the orthopedic surgery clinics, not in the rehab care. I think the hip x-ray is a really good marker. It's so concrete. And so I really like that. I guess a more specific measure might be getting migration percentage in the radiology report on the hip.
On the
And then, depending on if his baseline measurements show that that's really good, then it might be shifting to an action of, if the migration percentage is greater than.
Right. So one
40%.
thing that we're doing at our center, I hope it's okay. I mean, I'm not working on it, it's PM&R, but we wanted to see if people were getting their x-rays. Well, when we looked at it, they weren't getting their x-rays. So we had to actually look at, were they referred for an x-ray? So we had to go back and look at where the failures were, and the failures were, did they even get referred for an x-ray? So then we worked on improving that. And once we get the improving and they were referred, now we're tracking, did they actually get the x-ray completed? and now we're tracking that. And then, you know, the next step might be when the x-ray is completed, is migration percentage reported in the result? So
Yeah.
we had to work on the radiologist being trained to report that. Otherwise, we don't have that information. So there are lots of little steps that could be in that package, right? And you might
So-
work on one step at a time.
Yeah, so Amy, though, the thing I was trying to get at, though, was I think hip x-rays is a great measure, just with the caveats that you said. But, you know, you have to expand the thought as, did they get a hip x-ray in concordance with the protocol based on when they had the last hip x-ray?
Right, whatever the time frame is that
Yeah,
he
so-
decides. Yeah.
Yeah, so their percentage of people getting hip x-rays may fluctuate, but they could have a nice high percentage of people that are keeping in protocol.
Oh, he needs to provide more detail with what's meaningful to them, because I don't know. I don't
Yep.
know. Yeah.
The other query for Wade might be whether they wanted to consider adding individuals who are GMFCS level 3.
Mm-hmm.
You know, he's clearly targeting the non-ambulatory, but I'm sure in
I
orthopedic.
think he's just trying to start off small. He intends to do full population. He just felt like they had to choose something that was a bite that they could get.
Yeah.
But they could add 3 and not add 1 and 2. I mean, and I know the durations for the recommended X-rays are longer for the 1s and 2s, and so and the frequency.
Yeah. So I think that's great. Great place to start. I just want to know how often he thinks they should have an X-ray. So like if he looks at the data monthly and he says, okay, we saw 15 kids that were 4s and 5s. Of those 15, 8 of them, according to protocol, should have had an X-ray at this visit. Now, did they? Right? So we'll see. Okay, and then he moved his car along a little bit. So clearly he likes.
Oh, he's like a keener. Oh my
he
goodness.
likes board games. So I thought that was fun.
We have to kick Wade out of the group if he's going to show us up like this.
It's good he looked to the last slide, though. We'll give him credit. And then the next one is the dystonia group, and this is basically what I cut and pasted from Booma's email. So if you can read that and just tell us what your group is thinking they're going to work towards.
Yeah. So sorry to not have really nice slides like Ed and Wade. And Booma took the lead on getting this survey out, and we have some preliminary responses. I'm having trouble reading that, but I can talk in general. So
I'll make it bigger.
Or but I can just speak to it. So we did a survey in the group, and it's actually good for advice here. So our top rated sort of area of focus was determining if pain was asked if the individual had dystonia. The other potential option was looking at whether dystonia is being diagnosed or not using some version of the hypertonia assessment tool. So those were the two that had the highest sort of idea support in the group. And then other ideas were videotaping of the neurologic examination. And then the one that had slightly lower ratings was asking whether there was documentation of asking individuals whether there were triggers for tone/dystonia.
Darcy, you mean that videotaping the neuro exam should be considered a part of standardized care?
Yeah, that's, I know it'll be a stretch. So I'd like to focus the discussion on the first 2 bullets. So I do think pain is missed a lot. And so, Ed, I was interested to see that your group also identified pain. We could definitely go down the pain route, and I think it would be really ripe for QI opportunities. But for me, it's an issue for all individuals with cerebral palsy, not just individuals with dystonia. And then I actually think the more important thing that might be driven by a QI initiative is I think a lot of people are still missing dystonia. And so what would be ripe for a sort of a QI opportunity there is looking at the physical examination and seeing whether things like velocity dependent tone and triggers for dystonia are built in. So if the group decides to go that way, I think we could look at our baseline evaluation by looking at what's documented currently in our physical examination. And I think we will find opportunities for improvement there. Speaking on behalf of Booma, I think she was worried about the hypertonia assessment tool being too big a beast to grasp at. It is something that can be put into clinical practice fairly easily, but it does have several steps. And so we might further, if the group wants to go that way, we might further break it down to just putting in 2 elements of the hypertonia assessment tool and seeing if we could drive that change.
What 2 elements do you think would be?
Well, I have a biased perspective. Ed is probably smiling here because he's been along for the hypertonia assessment tool ride for a long time as well. So I think the easiest thing to put in is the doing a slow stretch and a fast stretch. And if you have increased tone with a fast stretch, that is consistent with spasticity. And for people who are predominantly dystonic, you will not elicit that velocity dependent tone. And that's your first key indicator that you're dealing with dystonia. An option would be something like a trigger. So
Yeah. Okay.
moving another part of the body that they have voluntary control and seeing if that triggers postures. And I think both of those things, you know, if we took away the mystification of calling it the hypertonia assessment tool and just articulated those 2 physical exam moves, I think we could probably drive practice change that would be meaningful. But I'm speaking on my own sort of thoughts and behalf here, and that's a little bit ahead of where the group's at.
I think that is, you know, based on what we do and what I do and how we try to do the HAD, it is hard to do in clinic. I think, you know, starting small and getting people familiar with that, that's a really, really, really good idea. But if you were to go back and look in your charts, because we are going to probably collect baseline data that way, in most cases, it sounds like. Let's say you went into a chart and you were looking for, did the provider indicate if they assessed dystonia? So it would be like dystonia, yes, no, because if they don't have it, you know, you have to think about how you're going to measure that.
Yeah, I think that what we'd have to do is sample a few different charts. So for example, within our clinical practice at Hull and Bloorview, we could identify a few markers for whether dystonia has been assessed. So
Okay.
within the label of the type of CP that the individual has. So we have standardized ways of communicating that. Or it might be in the actual examination, either by the PT or the physician looking for this velocity dependent tone and triggers of dystonia. We're fairly focused on it, so we'd find it in our practice, but that's why I think we need to look at other people's practice to see what their markers are.
Yeah, I have a quick question on that, Darcy, because, and so I'm assuming when I look at the mix of people that signed up for your group, you're about half and half between sort of movement orders focused people. I think you're the exception as the developmental pediatrician that does a lot of work in that area, and PM&R. And so I presume that a neurologist is going to have a different set of exam points and is going to be potentially more focused on dystonia than, say, a PM&R physician would be. Is that, are you paying attention to that sort of mix, or is it too early to say because you haven't gotten together as a group?
We haven't figured out how to measure our baseline, but that's why I think there may be different markers to get the baseline within the groups. And I think we do need to facilitate some discussion. I do think the neurologists are going to be better at documenting their neurologic examination than the other physicians.
Yeah. Yeah.
Well, that's an interesting point.
Interesting.
So consider the provider that you're going to be looking for the teams. I don't know how many groups, how many centers are going to work on this. You do want to consider what type of visit this is and who the provider is. And ideally, if you could look, whatever the markers are, let's say in your operational definitions, which we're going to talk about in a little bit, you define dystonia is indicated in the note either by it's in type of CP, it's in the physical examination, somewhere the hat or something, like whatever those criteria for you to give that chart a yes.
Yeah.
That dystonia was mentioned, right?
Yeah.
Versus a no, let's say. Yeah. Okay.
And then if the group decides to go with pain, then similar to what we talked about with Ed, it could be, you know, is pain being asked at, or if we're finding that is high at baseline, then is it being, is there some sort of severity or frequency measure that's documented? And then if we find that's good, then, you know, is an intervention being developed to address the pains?
Right. So if you, when you go back and look at these things and you see that, let's say you look at 20 charts and all 20 had dystonia commented on or assessed, then you kind of know, well, then we can look more at the next step, which is pain. If you go back and look at these 20 charts and 2 mention dystonia, then you might not, if you wanted to look at both dystonia and pain, you're going to get not many at all, but you'll see.
Darcy, it seems to me there should be some connection between the pain and the dystonia for this project. So in other words, in adults with CP, we're just interested to know, are they having any issues with pain? But over here, it would seem like your interest is that, is the pain something that can be helped by treatment of the dystonia? What do you think about that?
Yeah, I think that's a wise point. So you're making the point, is the pain associated or triggered by dystonia? Because we know there's many causes of pain, cerebral palsy. So some sort of connection there. That's a good point.
And do you think that you would look at all comers, all people that come with CP to these clinics, or is there a certain group you're going to look at?
Well, I was just going to ask a question of the group related to that. So again, one of the potential disadvantages of having a dystonia subgroup is I suspect we have a lot of people that are really interested in dystonia that are in the group. And it's probably other people that we want to drive change in practice around. So for example, in Ontario, where I'm based, we have several community rehab centers that feed in and refer us children for tertiary management. And I can't tell you how many times the child's referred with spastic quadriplegic CP that the child has severe generalized dystonia, and the treatment interventions are completely different. So should we each be trying to recruit a community-based subgroup to do the partnering QI activities with? Because, you know, I think that's a relevant question for us.
So I have a strong bias on this, and I don't know that I'm in a position to influence, but what Adam Ostendorf has done by adding, you know, a set of questions that any clinician can ask, but read on epilepsy and sort of rescue meds and opportunities for refractory epilepsy surgery and things like that. To me, that's such high value. And to me, the problem with sort of focusing on pain is you'll get pain, if you don't do it in a generalized way, you'll be able to focus on pain for the people that have dystonia that have been correctly diagnosed at the sites that do a good job. And what I really hope we'll get out of this is like the 2 measures out of the hat that make it so broadly people that come through CPRN centers get diagnosed with dystonia if they have it, and then turn towards the treatments for pain and whatnot. It's my bias.
Paul, I agree with that. I do think that the lost opportunity, if we don't choose something I'll just say the hat, but I agree, Amy, that it's not going to be the complete hat. It's going to be some focused. I think that really is the opportunity I'd prefer, but it is a group process.
Yeah, yeah.
Now the survey ranked Payne higher, but I suspect we'll be able to influence that once we have a little bit of a group discussion.
Mm-hmm.
Good.
Good.
Good luck.
Excellent. So good. So let's move on if that's okay. Can we keep going, or does anybody have any further questions about dystonia at the moment? Okay, so the next slide is about measures and ways to categorize measures. And I'm assuming a lot of people know these things, but we're just going to go really fast through these. So in quality improvement work, there are outcome measures that the patient experiences, and there are process measures about our process that the care providers experience. There's also some other kinds of measures that are done in quality improvement work. One of those is called a balancing measure, and another one is an all or none measure. So let me talk about an all or none measure first. So an all or none measure is kind of like, I'll use the pump protocol as an example. The pump infection prevention protocol is 13 steps. So if in order to get a passing score, the person had to complete all 13 steps, then that would be an all or none. It's you either get a yes or no based on did you do all 13 or not. You don't get partial credit for 6 out of the 13 steps, okay? So some quality improvement projects use a measure like that. Some people call it a bundle, right? Like did you achieve a bundle? We sometimes use that in our torticollis. To be successful in torticollis, you have to complete this bundle instead of all or none, but it's basically an all or none. A balancing measure is totally something different. So in quality improvement, you're changing the system somehow. So when you do this change to the system, you're kind of perturbing things. You want to make sure that you didn't make something else worse along the way, right? So let's say you make everybody do the hat for very long and they have to videotape it, but now there's no time to do anything. You no longer can get weights on the kids because you're using all the time to do the hat. So you need a balancing measure to make sure you didn't make something else worse in the process of changing the process. So that's called a balancing measure. Another example of that in our project where we changed we changed the way therapists were documenting what they delivered in the interventions, and we used a checklist. So they had to click a checklist. Well, our balancing measure was we videotaped some treatment sessions, a sample, and we had another group of people watch those videotapes and check off what they observed treatment interventions that were delivered, and we measured agreement with what the therapist who actually delivered the treatment put in the medical record, because we were thinking that because it's a checklist and Amy said they should do it, people will just quickly go through it, and they didn't really deliver those things. So our balancing measure was to make sure that there was agreement between what somebody else watched on the video and how they would document it and what the treating provider did in real time. So that's a balancing measure. And then of course there's lots of units of measurement. You might do time, weight, you might count things, or you might have categories. So depending on the type of unit of measurement, there are different charts to document change in quality improvement. But you don't need to worry about that. We'll worry about it when we decide what types you're collecting. So the next slide is just operationalizing these measures, and this is really important, right? So this worksheet that I sent out today is what your group is going to complete for the next time. So you're going to report back next time we meet like this on these things. So you're going to describe your measure, the rationale, the evidence, the population, the data source. Are you doing this from paper? Are you going to look up in Epic? How are you doing this? What's your sampling plan? Are you going to take 3 charts a week for the last 3 months? And we'll go over how many data points you should have in this baseline, and so on. And this is going to be hard, and this is going to make you rethink what you're measuring, and you're going to test out if what you want to measure is possible and gives you the information you need to have. Okay. Of course, we're also going to learn if the data is repeatable, reproducible, and accurate. for example, and this was again the pump project, they're collecting their data quarterly, and they want to make sure that in all patients that got intrathecal baclofen pump surgery, they want to decrease the surgical site infection rate from blank to blank by such and such a date. That's their outcome measure. But they first had to define what infection is. So they define infection, a culture positive wound, or CSF infection, or exposed hardware, and it must occur within 90 days of implanting the pump. So that would be counted as an infection, and that was how they operationally defined it. Then they also have a process measure, which was to increase the mean number of this infection prevention protocol from 0% to 80%. So they didn't have an infection prevention protocol. So when they went to look at the baseline, they just called it 0 because they didn't have any protocol. And their goal was 80%. And the range, that word range shouldn't be on this slide. That was supposed to go somewhere else, so that's confusing. So they just decided on the 80%. They didn't have any evidence to support the 80%. They thought, what's realistic, okay? And then they're using this 13-step infection reduction protocol in the OR, and that's their intervention, that they're measuring the number of steps. And it is not an all or none measurement. They're going to measure the percent of steps. So if there's 4 pumps in that quarter, then there's 52 potential steps, and that's what would be in their denominator that should have been followed that quarter. Make sense? Okay, good. So then how you're going to get the data, again, you're probably going to collect it manually, and you're going to take a random sample. You're not going to collect every person for your baseline, sure, certainly, but you do want it to be representative of the entire population and probably of a variety of providers. You don't want to only collect data from Ed's charts because he usually assesses dystonia, right? You want to have a variety. And then the ways you can present your data, we all know you could do it in a histogram form. So here's a nice one that looks like it's distributed normally. This is like time till you get in rooms. This
Amy?
is just an example. Yeah.
What did you mean in the previous slide about EMR that you're dependent on others? You mean like for the data pool, or what did you mean by that?
Oh, you depend on others? Yes. If it's electronic and someone else is going to pull it for you, yes. Or
Okay.
are you going to go through it? So are you going to wait for, like we have the Epic Universe. That's how we get our data out. I don't know what you do. Or you could either ask them to pull a report for you, or you could just go into the charts yourself.
Okay.
It makes it, that will, you'll have to take that into consideration when you decide what data you're going to pull and how many you're going to pull for.
Yeah. Okay.
So you could present your data in a histogram, and the y-axis here, you can see the values on the y-axis, and the data looks like it's distributed normally, but certainly depending on how you report the axes, the data could look like it's skewed. So that's just something to show you. Then the next slide is about a Pareto chart. Oh, sorry, you see this? And Pareto, you don't need to read all the details about this. We could look at this later. But a Pareto chart actually looks at failures in your system. So if you had, I'll show you an example here. If you were looking at, and this was from that article that we read for the first thing about the fever, neutrophil fever patients receiving antibiotics quickly, right, in the ED. They looked at, when they looked at their data, okay, their baseline data, they wrote down the reasons there were failures. So if you look back and you see that, let's use the hip as an example. So did they get the x-rays? You look back and you see that 10 kids didn't get x-rays, and of those 10, 8 of them didn't even have a referral put in, then that's a reason that they didn't get their x-ray. There wasn't even a referral, so that would be a failure, and you would you would calculate how many failures were because of that. So if you look at this, the first bar is delay in antibiotic ordering after they arrived. The second one is lack of standardization of antibiotic selection. The next one is the identification of those patients weren't at the time that they came into the ED. And you just mark the frequency with which each failure occurred in your sampling, okay? And then this helps you understand where the failures are in your process towards getting, let's say, your hip x-rays. So that where there's a lot of failures, that will help you focus on maybe where your interventions need to focus. For example, in this one, there weren't that many kids that didn't put their EMLA cream on, so we might not focus on that process. We would choose to focus on where there's a lot of numbers failing in that group. Make sense? I probably didn't explain that well, but it's a pretty neat process.
Well, it makes a lot of sense. I think we all like the 80-20 rule too.
Yeah. And so it's
money.
Yeah, it really makes a lot of sense. I'll give you another example that we recently found, and we're going to be on time here. So we wanted to see how many children that we thought should have completed an episode of constraint therapy actually did complete an episode of constraint therapy. And we went back and sampled some charts, pretty many actually, all the kids that we thought that had hemiplegia, that, you know, we thought there were some other criteria how we decided. And then we did a Pareto chart to see where our failures were, to see why they didn't complete it. And completing an episode included, you had your baseline assessment and your post-assessment. So if you just did the treatments and there was no post-assessment to measure change, you failed. You did not complete an episode of constraint. So what we learned from our Pareto chart is that many of the kids did not have the post-assessment. And we said, oh, we got to focus on getting that done. So now we had to see what happened. Why aren't we getting these scheduled? So that allowed us to target where we needed to focus our interventions. And we hope that, you know, we can do better. So that's what a Pareto chart is. But what we're going to look at today really is a run chart, and how you're going to look at your baseline data and what you're going to look at. So you are going to take some observation to establish a baseline, and you have to take a minimum of 12 points, okay? But really 20 to 30. But we can do 12. That's totally fine. That's what a lot of people have done. It kind of depends on the frequency of the occurrence of what you're measuring. So like a pump infection doesn't happen very often. So that process is going to take a long time, right? Versus every time you see a patient in clinic, you need to evaluate pain. That should be happening much more frequently than a pump infection, right? So the observations you look at depends on the frequency, the seasonality of things, how much variability is in the data, and how hard it is to get the data. That's the expense. And you're going to create a graph. You're going to plot the values for each of those observations that you took. You're going to calculate the median, and then we're going to annotate on that graph. So let me show you, this is sort of going to be our run chart where we're going to show our story. And the second thing I sent you today was an example of the template for how to do your run chart. So the template is you enter the data and then it automatically graphs it. It's it's fun to do if you want to, but I'm happy to take your data and put it in these charts for you. Okay, so this is an example run chart. Can everybody see this? On the x-axis, in this particular example, they collected data weekly. Okay, and then let's just assume that up to this point, which looks like it was about May 15th, 2004, these dots are this is the dot of what they collected that week. So let's say that week they looked at the percentage of patients discharged within 4 hours of meeting their goals. So they weren't delayed in their discharge. So let's say they looked at I don't know, 10 discharges that week. And looks like about 21% of those 10 discharges left within 4 hours of meeting their goals, right? So you plot that point for that week. And then the next week they did another one and they were at about 30% of the number of discharges, the percentage. And then the next week they did another one and that one was a little better, almost 50%, and so on and so forth. So you're just going to plot these lines. I'll take care of the red line in the middle, okay? That's going to be the median for that time frame. And then it jumps up when you start to do things to your process. For example, let's say this is when this yellow thing, they start to annotate their run chart to show you what they did. They did something in this yellow box to hopefully improve the percentage of people discharged within 4 hours of meeting goals. And you can see that the dots start to change. But we're not going to worry about that right now. We're just going to worry about this baseline over here, okay? So your job is going to be to collect at least 12 points on whatever measure you decide for your baseline. And it's good if it's bad, because then we can improve a lot. So don't feel that you have to report a good number. The green line at the top is the goal that you set. Remember how the pump people said 80%? And then the red line is the median and the dot is the percent of patients. And we will make this chart more complicated as we go along, but for starters, this is what it looks like for starters. So for next time, try to hone in on the problem that you're going to focus on, complete the operational definitions, and collect some baseline data on your measure. And as you're doing that, you might tweak your measure a little bit and make some decisions as a group, and we look forward to hearing about that. And I know that we talked about meeting monthly, and I know Wade, apparently this Thursday time is never a good time, so I don't know if we want to alternate times or what. I just wanted to bring that up. In that, I think, and this just to remind you where we want our little red car to be by the end of September. We really want to define our aim and our measure. So by doing the operational definitions and looking at your baseline data, we will be able to get there, move our little car along. So what do you think is possible? I mean, it sounds like we're, I don't expect every group to be able to be moving forward at the same pace, but so far everybody seems like they're making some decisions and moving towards that direction.
I think
Amy, okay. Go ahead, Darcy.
I was just going to say, I think the art is in simplicity. I was just looking at the run charts, and you got to choose something really simple. And as you correctly say, that's going to be low at baseline, that's going to be responsive to intervention that's meaningful. So this is where the practical clinician perspective is really helpful.
Yeah, and I think another thing about when thinking like that is, let's make the first thing simple because we're learning.
Yeah.
Okay, and let's do well, and then we can build on it.
Yeah. So our simple baseline might be, is the physical examination evaluating for dystonia, and we'll maybe tweak how we're going to look at that, and then drive more people doing a good job of evaluating for dystonia, which I think will be meaningful at a clinician community level.
Very meaningful. I agree. Ed, did you have a comment?
Just going to ask how you want to arrive at a different time for Wade. I mean, can we get Wade's times and then see how they compare the rest of us? Or?
I realized after I responded to his email that I should have asked him, well, what time does work for you? So yeah, we'll have to do that.
Now, I want to show surgeons sometimes say 6 a.m. That's not. I'm very, very busy at that time.
Okay.
Wade's in a different time zone than us, Ed.
Literally and figuratively, right?
Yeah.
But just figuratively.
Yeah. Well, we'll see. I don't know. How do you guys feel about alternating times?
You know, whatever I can fit in, you know, it works. That's fine.
Mhm.
If we can find a time that works for all of us, it's a small group. Yeah.
Yeah, I'm flexible.
Okay.
Tuesday's not a good day for me.
Yeah, so I think I can probably poll on this. Can you guys hear me?
Yep.
Yeah.
Yeah, okay. I think I can probably poll on this. I mean, between different meetings that we've done with the registry elements and Estonia, although I think the Estonia meeting is on Monday. I think we can possibly find a time, or we may have to go to an alternation thing. So I can work with you, Amy, to try to find another time. I can do, you can do a doodle poll. I can do a doodle poll. I think I think generally it's sort of in the 4 to 6 time frame. East Coast time seems to be the range. It's just really finding out if there's a day that can be, once a month can be consistently available for people.
I mean, I would like to not lose this time for September, just because, we've sort of got a little bit of momentum. And even if we just get, baseline data from a couple centers on a couple things, I think that would be progress. So I would advocate that we keep the September time, and then when we can change, we will change, and when we can start alternating, we can do that.
That's fine. I can look for a time that we could add as an alternating time.
Okay.
Yeah.
And then, so that next meeting, I don't like to hang up till we know the next one is, oh heavens, are we going to be at AACPDM?
No, we're not. It's going to be the 17th, I think, at
Okay.
this time. 17th.
Yeah.
Okay.
Yeah. You have to bring apples and honey.
Oh, no, the next day. You're good.
Well, yeah, but we can't have the meeting the next day, so I have to bring the apples and honey
Okay.
that day.
Okay. I'll have some here. You have some there.
Okay.
It's the Jewish New Year, so we'll all do that. The other thing is I would be willing to do later on a Thursday night. It is Thursday, right? If that were worked for Wade and the rest of you guys. I'm fine with doing the evening.
I can do a later meeting once a month.
So maybe we could offer that to Wade.
Later meetings aren't super great for me, but
Okay.
And Amy, are you just talking about an hour later?
an hour later.
I would do the evening, if it was 7 o'clock, we could do that. I mean,
Yeah, that's not good for Darcy though. Like I
Yeah,
love to
okay.
get them started by 6 or whatnot. I hate to cut into people's dinners and whatnot. So
yeah,
even if it's once a month, but
yeah. Okay, it's just an option. Just,
Yep.
Let's see what works for Wade and we can go from there. But in the meantime, the 17th will be our next meeting at 4. And then Ed, you win the prize in collecting some baseline data. And if it's at 2 centers, great. If it's at 4 centers, great. If it's just at your center, great. Whatever works. Let me know how I can help.
Okay, great, Amy. So I might call on you. I'm going to get the group together, and I might call on. Well, maybe when I get the group together, I'll call on you to come.
Okay.
We'll see.
Okay. So got to show up with some baseline data September 17th, which
All
feels
right.
really soon. Sorry. But we can do it. 12 data points. That's it.
Thanks, everyone.
Okay.
Okay.
Any
all right, bye-bye.
any other questions? We're all good for tonight?
Yeah.
all good.
Okay.
Amy, I enjoyed your presentation and your practical, experienced aspect to it. So thank you. It was good.
Oh, thank you. It's great to see you and your hospital behind you. And I'll wear a different shirt color next time. I'm sorry about the floating head. That's really funny.
I
All right.
think
Bye, you guys.
yeah. All right. Bye. Thanks, Amy.
Have a great
Bye,
night.
everybody.
Why can't I find out how to turn off Zoom?
Me neither. In the Zoom
Oh, there it is. I can turn it off.
eternity.
All right. Bye, Amy.